is a special lecture in our Yale Cancer Center Grand Round series, and it's the Blanche Tallman lecture series. So this lecture series was established in 2012 by Dr. Marvin Sears, who I believe will be attending today as well. Dr. Sears was a longtime chair and founder of ophthalmology and visual sciences at Yale. And the lecture was established in honor of his mother, Blanche Tallman, who passed away from acute myeloid leukemia. So to our delight, this was the first lecture series at Yale dedicated solely to hematologic malignancies. And it continues to bring to Yale pioneers that have made major contributions to our understanding of the current trends in hematologic malignancies. So it is an absolute pleasure to introduce Dr. Irene Ghobrial today as our special lecturer. So Dr. Ghobrial is professor of medicine at Harvard Medical School. She received her MD from Cairo University School of Medicine in Egypt, and she then completed her internal medicine training at Wayne State University and her hematology oncology subspecialty training at Mayo Clinic College of Medicine. In 2005, she joined Dana-Farber Cancer Institute in the field of Waldenstrom's microglobulinemia and multiple myeloma. So Dr. Ghobrial, as you will all see, has risen to become one of the world's leaders in the gammopathy field. Not only has she advanced major novel treatments to the clinic, but she now also focuses on early detection and interception to prevent progression to full-blown multiple myeloma. Dr. Ghobrial has a broad background in the biology of multiple myeloma and in the bone marrow niche, so important in the focus on MGUS and smoldering myeloma and, again, preventing disease. And her research, her knowledge, expertise allow us to define both cell autonomous and bone marrow niche dependent, and also genetic and epigenetic mechanisms of disease progression. And we couldn't be more excited to hear your talk today. So welcome. We wish we were in person, but this is still wonderful. And at least we didn't have to cancel.
Yes. Well, thank you so much, Stephanie. And as you said, it's really a pleasure and honor to be here. And I'm sorry that it's not in person, but it's New England and we all know how to deal with that, I guess. So I'll take you through a little bit of what we do in the lab and how we translate it into the clinic on the promise of early detection and interception. These are my conflicts of interests. So I'll just start with a simple question that many of us ask ourselves. In general, in every cancer center, when you see patients, it's because they either had symptoms and they went to see their primary care doctor, or by accident, something happened in their blood works. They had a little bit of anemia, a little bit of a higher white count, and that led to further workup, which led to the diagnosis of cancer, and then they get referred to you. But if you think about it, this means that we are waiting for things to happen and then we react to cancer. And by chance, some of those may, by good luck, have an early cancer and we can diagnose it early and we can cure it. But many of them actually have stage 3, stage 4 cancer. And we do sit down with them and say, we may give you some treatment, but we may not cure the disease. And in fact, if you think about it, pharmaceutical companies as well as cancer centers put millions and billions of dollars into developing therapies that can change the survival of metastatic cancer by 3 or 4 months, and we consider that success. So what can we do to change that? How can we become less reactive to cancer and be more proactive to cancer? Trying to find it early before it becomes symptomatic, trying to define it early, and then by doing that, you can intervene early and make a difference in the survival of those patients. Now, I would probably say that myeloma is a great example of that. As a potential model system for early detection and interception, we know that myeloma has a well-known clinically defined precursor condition, monoclonal gammopathy of undetermined significance, and then yet another stage of the disease that progresses just before the active cancer, sort of a stage 1, stage 2 breast cancer, if you want to call it, and that's the asymptomatic smoldering myeloma. Now, I was lucky enough to be trained by Bob Kyle at Mayo Clinic, who actually coined both of those terms, monoclonal gammopathy of undetermined significance and smoldering myeloma. And he had this amazing vision because he thought that when he described those asymptomatic patients who are just walking around with a very small, tiny monoclonal protein, that they should actually be watched carefully and they may actually progress to develop the disease. And in fact, him and Jan Waldenstrom had a big discussion where Jan Waldestrom wanted to call it benign gammopathy because those patients are completely benign, and why would we worry them? Yet Bob Kyle was so good in thinking ahead and thinking that there is a potential of cancer development, and he coined the name of undetermined significance to give it that sense of urgency of understanding who will progress in their lifetime and potentially preventing it. And indeed, even the name smoldering myeloma gives you that urgency that it's going to be on fire very soon. So let's do something about it. So indeed, he had that vision that we should think of the mechanisms of disease progression in asymptomatic people and potentially intercepting early. Now, in the older days, we didn't have good drugs. We had melphalan, prednisone, VAD, chemotherapy. So maybe intercepting early may not make sense. And indeed, the trend or the standard of care was watch and wait until people have symptoms and end organ damage, and then we treat them, because we had palliative care and myeloma survival was only 3 to 5 years. But now we have 30 new drugs approved for myeloma. We have amazing responses. And the question is truly, can we change that thinking of disease interception at an earlier time point? Now, the other important piece to think about is myeloma is more common in African Americans, in people of African descent, 2 times or even higher more common to happen at an earlier, younger age. In fact, we know that myeloma is more common because they have an earlier stage of MGUS development, not because usually of an MGUS transition to myeloma. Not that we know of, but we don't think that there is a faster transition from MGUS to myeloma. So really understanding what causes early development of MGUS in an African American population at a younger age could potentially help us understand why they've developed myeloma more, but also intercepting it early, because most of those patients, by the time they're diagnosed, they're either misdiagnosed because anemia is very common in African Americans, or because of renal failure. And again, renal failure is more common, so they're getting misdiagnosed, they don't have the workup. And even when they have the workup and the disease assessment, they do not get the access to clinical trials and to CAR T and to transplant and all of the options that we have. So the survival of myeloma in African Americans, unfortunately, is still very poor. Despite all of the amazing advances we still have a huge discrepancy there. So potentially closing that gap would be critical for us to understand how to change the survival of myeloma. So with that in mind, our hypothesis, really, our model is, why are we doing it any different than other cancers? If you think of breast cancer, for example, you screen early because cancer screening saves lives. And I would tell you that a blood test for a serum protein electrophoresis, a monoclonal protein, is much easier, more sensitive, and more specific, and potentially much better for us, because I would rather get a blood sample done than mammography or colonoscopy. It's much easier to do. But even though with that, we don't screen for blood cancers. They're easy to screen, but we don't screen for them. And even when we find the monoclonal gammopathies, when I find MGUS, and it's very common in the general population, 3 to 5% over the age of 50, or even when I find smoldering myeloma, the standard of care to date is still telling them, watch and wait until you have anemia, renal failure, fractures in your bones or lesions in your bones, and high calcium, what we call the CRAB criteria. That would be just like telling a woman with breast cancer, DCIS or stage 1, stage 2 breast cancer, you know what, you're asymptomatic. Go watch and wait until you have metastases everywhere, fractures in your bones, and then I'll treat you. Now, you'll have a lawsuit in that case. So why are we not getting lawsuits in myeloma when we do that exact same idea? So really, we need to rethink the way we think of treatment of myeloma and train ourselves to think that's not actually the right way of thinking. Maybe again, 30, 40 years ago, when we only had melphalan and prednisone, it was a good idea. Right now, it may not be a good idea to watch and wait for those patients, or as my patients call it, watch and worry. So how do we change that? We have 3 different areas or pillars of work that we're doing both in the lab and in the clinic. We said, well, let's detect early, let's screen early, because currently most patients with MGUS and smoldering myeloma are found purely incidentally. So let's really understand better when you screen those patients, what is the prevalence, but also who will progress and who will not in their lifetime. The next question is, let's risk stratify those patients. Not every MGUS we diagnose will go on to progress to myeloma. So the question is, who in their lifetime will progress to myeloma? Because these are the ones you want to treat, and the others, you want to tell them you're okay, you're going to live a normal life without having to develop myeloma. And that differential is critical so that you can truly personalize that risk stratification for patients. And then the third one is, unless you know that you can change the survival of those patients, unless you can really intercept and change their survival, why are you screening for it? Because otherwise you're causing anxiety and no change. So truly, I reverse it usually and say interception is more important, because without interception, we should not be screening and we should not be stratifying those patients. So let's start with early detection and why it matters. We have seen lots of nationwide studies, the first one in Olmsted County, where we indeed know the prevalence of MGUS in the general population, 3 to 5% over the age of 50. But that was found in mostly Caucasian population in the area of Olmsted County in Minnesota. So the question was, can we really detect in a much more sensitive way than serum protein electrophoresis, and in a high risk population, not in the general population, what is the prevalence of monoclonal gammopsies? And does it really occur in a younger age in African Americans? So there has been some studies indicating that people of African descent, as well as people with a first degree family member, are likely 2 to 3 times higher, have a higher chance of developing myeloma. So we wanted to ask why in high risk screened population. And this was started 4 years ago with the help of a Stand Up to Cancer Dream Team application, where we started to say, let's screen in the US for myeloma. And we said we will do it nationwide. So it's online. As you can see here, you get a QR code. And if you meet the eligibility criteria, you can sign up wherever you are, and we send you a kit at home. You go to a Quest diagnostic and you send us the blood sample. And the second thing we did is we did it by mass spectrometry, which is much more sensitive than serum protein electrophoresis. Now, to do that effort, we said that we want to screen 30,000 individuals to potentially get 10% screen positive, because that's the number that from our preliminary data indicated we will have a positive number. And then we will follow those 3,000 people to understand genomics, genetics, mechanisms of disease progression, immune microenvironment or non-immune, epidemiological causes like obesity, inflammation, autoimmune diseases, and of course, develop therapeutics and imaging modalities for those people. Now, as we started, we really had to learn to have boots on the ground, to really do the effort, because if you talk to anyone about myeloma, even the African American population would tell you, I didn't even know that it's more common in the Black community than in the white population. So we had to do effort to even educate what is myeloma, to gain the trust of the African American population, and then start screening them. And that was a lot of effort from a team that we hired, just going to church events, going to health fair events, understanding how to work with our Congress people like Ayanna Presley here. And of course, COVID hit and all our effort got shut down because you cannot do that on Zoom. So it really took us a lot of effort to try and restart all of this. And indeed, we just started to go back to health fair events and restarting it. While we were in COVID, we said, well, let's look at data sets and samples that are already collected in other cohorts. And this is when we turned to the Mass General Brigham. So Mass General Brigham is a huge sample collection study that's been going on now for the last 10 years, with samples as well as, of course, clinical data annotation from all of the partners' healthcare system, or MGB as we call it now. So we collected the same criteria, African American or people of first degree family members, from 80,000 samples that we have in MGB. And total enrolled so far is 12,592. Of those from the US is 6,485. We also opened a Promise South Africa one where actually they're getting almost to 2,000 samples now that they've recruited prospectively. And we're also going on into opening it now in Israel because of the family histories, as well as many other countries that we can do. And we were screening in my lab almost 1,000 samples a week, and we can do even more because mass spectrometry can get to a higher throughput level, and you can then get detection of monoclonal proteins as well as light chains in a very quantitative way compared to serum protein electrophoresis. In fact, we set up the normals for binding site, and now we are part of their FDA approval, hopefully soon, for binding site. So these are just some of the numbers showing you from MGB, from Promise South Africa and Promise US, but this is the largest number of African Americans who have been screened to date, as well as people with family history. And it was interesting when we saw families with 5, 6, 7 members who have MGUS and myeloma and lymphoma. Now you start asking questions of germline events, of events that really can lead to that development in an early risk population. So this is the paper that we published last year just for the first 7,000 people, and now we're actually going on for the larger cohort. And as you can see here, the people with a family history of a blood cancer were 3,866, and people of African descent or Blacks were 2,439. And this is the mass spectrometry, and I call this the Christmas tree. So mass spectrometry is quantifiable, and you can also reflex it to LC-MS to give you a further detection of the monoclonal protein. So all of these were truly monoclonal proteins that were quantified and verified. What we found is anything above 1 gram per liter is something that you can also detect by serum protein electrophoresis, because we did SPEP, the traditional method, in some of the samples, or in almost all of the samples that we did. Anything below that, at 0.2 grams per liter, you could potentially also detect it by immunofixation, but of course you have quantification and much more sensitivity by the mass spectrometry. So we kept those terms as they are. But interestingly, and I still remember it when we got the first data because we couldn't believe it, we found another 20% of people with very small monoclonal gammopathies that were much lower than the level that we can detect by immunofixation. And at first we said, well, these are probably errors. So we reconfirmed them. Maybe these are, people who have infections. So we rescreened them. We kept going on to try and understand what this is. And we finally said, well, no one has ever discovered, very small monoclonal proteins. Let the research tell us what it is. Now, we wanted to term this something separate than MGUS because we really didn't know if this is MGUS or not. So we called it MGIP, monoclonal gammopathy of indeterminate potential, a la CHIP, clonal hematopoiesis of indeterminate potential. And the story goes that David Steensma is the one who coined the name CHIP. And I saw him once and he said, well, I called CHIP based on MGUS. I was trying to imitate what Dr. Kyle had done. So now we called MGIP based on CHIP, and it keeps going round and round in hematological malignancies. But what is this CHIP and what is this MGUS prevalence in this high-risk population? So you can see here by age that MGIP is very common, almost 20% of the population, and it increases with age. But as you go on with age, the MGUS proportion of those monoclonal gammopathies increases more. And then light chain MGUS was actually a very small number in that population. If I just take it standard values, 3% of the population in general population is what Dr. Kyle had described before, and that was based on SPEP. If you double it because of the higher risk population, which is true, 6% in our population are SPEP positive. And then if you look by mass spectrometry, because it's much more sensitive and can get you immunofixation, then we are 13%, and that's not even accounting for the MGIP. So a large proportion of our high-risk individuals have MGUS, and we need to understand better why they have it, but also who would progress in their lifetime. Now, in general, all monoclonal gammopathies were associated with worse overall survival. And it was not because of myeloma, it was also because of many other all-cause mortalities, autoimmune diseases, cardiovascular disease, many other lymphomas. So we started seeing maybe MGUS and immune dysregulation in those patients may have other effects, not just myeloma development. And that's leading us to understand more into correlations of MGUS and CHIP mutations. Both of them cause inflammation, potentially increased cardiovascular risk. We're trying to understand how that regulates the immune system and immune aging, how it correlates with autoimmune diseases, and so many other questions. But what we were intrigued by is those MGIPs and why were they present in many of those people. And most of those MGIPs were actually IgM MGIP, not IgG or IgA. So the first thing we said, well, maybe it's an isotype class switch. This is the precursor of myeloma, and it's IgM positive, and then it class switches to IgG as it progresses, and this is the first event that requires the mutations. The other a possibility was maybe these are lymphomas and they secrete very low levels of IgM that's non-detectable by SPEP. And in general, we don't even screen for lymphomas by serum protein electrophoresis. So we're not detecting enough of the CLLs and low-grade lymphomas, and now we have a technology that can be more sensitive. And indeed, for us to prove that, we took samples from healthy donors, from 2 people who have MGUS, one of them had MGUS and MGIP, and from 2 participants who had MGIP. And we did CD19 and CD138 selection of the peripheral blood because we don't have bone marrow biopsies on those patients. And indeed, we did first single cell sequencing for VDJ, so now for the BCR to see if they have clonal BCR in those patients. And then, of course, we did gene expression profiling afterwards with the single cell RNA sequencing. And what was surprising, as you can see here for this patient, for example, they had 1 clone that was all VDJ, the same clone. And you can see that in this patient. All of those cells, so this is single cell RNA sequencing in the blood, all of the cells were for 1 clone only in that patient. And then this second patient had 2 different clones. As you can see, one of them was very high, which is the red one here, and then the second one here in the orange one. And indeed, we reconfirmed that those patients, one of them was indeed an early CLL case because we did flow cytometry. And because this patient had almost 60% of the cells are all clonal, we were able to do whole genome sequencing on that sample. And indeed, it was an atypical lymphoma, likely a post-germinal B-cell lymphoma, so either DLBCL or something like a marginal zone, which was MYD88 positive, and it had copy number alterations, as you see here, chromosome 3, chromosome 18, with a gain of those chromosomes. So indeed, by both DNA, by protein level in flow cytometry, and by RNA sequencing, we were able to indicate that 2 of those cases were lymphomas. Now we're expanding that cohort to another 40, 50 samples with single cell RNA sequencing, and then it will be followed by DNA sequencing, of course, if we find this positive. But that opens the door for saying we can screen also for other lymphomas and not just for myeloma. And the question is, what are all of those monoclonal gammopathies doing in our general population? So to answer some of those questions, we're moving on to other bigger cohorts. So now we're talking to the UK Biobank. They have 500,000 samples that have been collected over 20 years. We're talking to NHANES and trying to get samples from NHANES. As you can see here, 7,937, another 8,000, and PLCO, another 14,000. We're also trying to see if we can get access to the Million Veterans Project, to all of us and many other cohorts that have already collected large numbers of samples to ask big questions of what is the prevalence in a high-risk population, but also what are those early monoclonal gammopathies doing to the general population. And then, of course, we have collaborations with Olink to try and look at the protein level in those patients with proteomics. So the next step I'll take you through is understanding mechanisms of disease progression. If you have MGUS or smoldering myeloma, you want to know what is my personal risk of going on to develop myeloma. And I don't have in the slides here what we just published yesterday night. It just came out in Lancet Hematology, a new dynamic model to understand risk of progression, because we know that the current clinical criteria, 20% plasma cells in your bone marrow, 2 grams M-spike, 20 light chain ratio for a smoldering myeloma are good, but not good enough, because they give you a 50% chance of progression in 2 years. And that's basically like flipping a coin, 50% chance of progressing, 50% chance of not progressing. So we need something better than that, or to improve on it. So we developed a dynamic model, and now this is a risk calculator. Any patient, any physician can use the risk calculator and have the prediction of 5 years, 10 years, 20 years, what is my personal risk based on clinical markers. But clinical markers are assessing the tumor burden, how many cancer cells you have. It doesn't give you the underlying biology, how fast are they growing. So we need more than that. The dynamic model helps you because the more data you enter in the light chain increase or the M-spike increase, it gives you the dynamics of tumor progression. But we need something as the genomics and the immune and other factors. So here's one of the first papers we published a few years ago, where we looked at whole exome sequencing in 250 patients with smoldering myeloma. And now we expanded it, of course, to many others. And we found that there were 3 main mechanisms of genomic aberrations that lead to progression, or that are associated strongly with progression to myeloma. And these were MAP kinase mutations like NRAS and KRAS, ATM and ATR and P53 mutations, DNA repair pathway, and of course MYC, alterations or translocations. In fact, I think that if we have MYC, we already have myeloma. And potentially some of those alterations are all secondary mutations and secondary alterations that occur when you're already going towards myeloma, when there's no coming back. And hopefully these will become routine in our understanding of if someone has smoldering myeloma and has one of those, likely they have very high risk of progression, and we should consider therapeutic interventions in them. Now, what we found lately is that one, many of our patients don't get bone marrow biopsies or serial bone marrow biopsies, and two, whole exome sequencing is okay, and it's not good enough because it doesn't give you the primary events, the translocations that occur in those patients. So this is a paper that just got published a few weeks ago, work from Ankit and Jean-Baptiste, where we took circulating tumor cells, isolated them, developed a method of low input DNA, and were able to do whole genome sequencing from as low as 30 to 50 cells that you can get in the peripheral blood. So you can see in MGUS and smoldering myeloma, many of them have small numbers of circulating tumor cells. And when you are able to capture them and purify them, you can do whole genome sequencing, and you don't even have to go deep sequencing because the purity is so good in those samples. So indeed, we had head-to-head comparison of circulating tumor cells versus bone marrow cells, so that you can show indeed that all of the clonal and subclonal events can also happen in the blood, and you don't need a bone marrow biopsy, but also head-to-head comparison to FISH, which is the standard of care that we have right now in myeloma, yet another 50-year-old technology. So indeed, of course, no surprise there that whole genome sequencing is better than FISH. Indeed, it can get you all of the translocations, but it can get you much more. You get mutations, you get copy number alterations, you can even get translocations you couldn't detect by FISH. And indeed, because you're purifying small numbers of cells, especially in the peripheral blood, you can do that multiple times during the serial development of a patient's progression. So you can ask the question, when the MYC clone is growing, what is going on, and when can I treat this patient? Now I'll move on to single cell. And I borrowed this slide from Aviv Regev, who basically tries to tell you why do we need to go to the single cell level. And it's basically when you do bulk sequencing, whether it's whole genome sequencing or bulk RNA sequencing, you're sequencing all of the cells mushed together like a smoothie. Now it tastes good, but you can't really tell the differences between a strawberry and a raspberry. You can't even tell if it's a good raspberry versus a mutant raspberry. Single cell sequencing gives you that. It gives you that ability to differentiate them from each other. And of course, spatial transcriptomics or spatial sequencing is the ultimate goal, where you get the whole fruit tart and you can understand better the localization of all of those cells in the environment. So what we did is we said, well, let's look at the tumor cells in the bone marrow compartment. And this is a study where we did it in collaboration with MIT and of course with the Broad. All of our work is with the Broad Institute, where we said we're lucky enough in MGUS and smoldering myeloma that not all of the plasma cells are actually malignant plasma cells. We have some of them are normal plasma cells. So the potential here is, instead of looking at inter-patient variability, healthy versus cancer patients, we can actually look at the intra-patient variability, healthy cells, plasma cells within one patient versus malignant plasma cells. And now you can ask the questions of, here are the normal plasma cells, here are the malignant plasma cells from the same patient. What are the differences in them? And can I understand that mechanism of early genomic events and transcriptional changes that occur with malignant transformation? Even within the same neoplastic cells, I can find subclusters that are very different from each other. There is a proliferating cluster, there is some that have higher expression of certain genes, and that can help you understand when the patient is treated, which subcluster may respond and which one may be resistant to therapy. Now we moved on to do even more work on that. So this was presented in ASH this year, where we showed 245 samples from 234 patients. Here we did not only do the GEX, the gene expression single cell sequencing, but we also did BCR profiling on all of those patients. So now you can get, with the VGJ or with the BCR sequencing, the clonality of those patients. So this just shows you the potential of really understanding the tumor compartment in those patients. We've done the same thing on circulating tumor cells, but I'm not showing that data here. So of course, with a huge number of samples, what was very interesting is indeed all of the malignant samples cluster separately, which was not surprising. We saw that before, and the normal plasma cells cluster together from all of the patients. And indeed, the more you look at the number of cells are increasing as you go on to myeloma, the malignant versus normal compartment. But what was interesting is we compared head-to-head cytogenetics from those patients with FISH, or when we have whole genome sequencing, to the single cell RNA sequencing data. And indeed, you can see that the hyperdeployed cases were confirmed. The 414, you can confirm it with FGFR3, 1114, with cyclin D1, 1416, and so on. So you can be very accurate in understanding who has a specific translocation. But then we said, well, 50% of our samples did not even have good FISH information. Either it failed, which happens a lot, or they gave us the FISH information with an IGH partner that we cannot detect. So we were basically blinded to know what is happening. So we used our single cell RNA sequencing to generate what could potentially be the cytogenetic information of those patients. So you can see here that all of the unavailable, or we didn't know what they were, we were able to reclassify them into specific cytogenetic abnormalities. And this is the confusion matrix showing you that indeed all of the unclassified, we were able to get them into a 414, 1114, and so on. Biggest number was the hyperdeployed numbers. So that can tell you that you can use RNA sequencing to basically predict what are the cytogenetic abnormalities at the single cell level. So now you can really say subclusters of those patients and subclonal abnormalities. And we took it even more because we have potentially the ability to identify rare events. You can now find 814 translocation, extremely rare in myeloma. We miss it in many patients, and now we can find it with this MAF-A. And you can even look at their expression of certain genes. So for example, they express high levels of MYC. They don't express other levels of other genes, for example, in 1416 or in 1420 translocation. So now you can really go into the genetics and the transcriptional changes that are occurring in those rare events. So when you go back to also looking at the normal versus malignant cells in those patients, you can also ask questions that are very specific to the phenotype of those patients. So for example, we always think that CD56 is highly expressed on malignant plasma cells. That's not actually true for the small numbers of 1416 and 1420 cells. They are negative for CD56. And you can go on. So now you can really say, if I'm going to develop a therapeutic target, not BCMA, but others, I want to understand whether it's highly expressed on those cells with certain genetic abnormalities. And those are the patients that I will not, or I will include in my clinical trial. Now, moving on to the gene expression data, you can see here, these are the top highly expressed or the top significantly downregulated genes across the spectrum from MGUS to smoldering myeloma to myeloma. And because again, we have huge numbers of cells, you have a better ability to detect genes that really are modulated as you go on to progress, like MLL-T3, which is a leukemia growth factor, as well, or transcriptional factor, as well as many other genes that get downregulated as you progress. But also you can identify new targets potentially for developing therapeutics or new bispecifics or new CAR-Ts. And then we developed a signature that was developed not from the normal plasma cells, but from the malignant plasma cells, and it was increasing as you go on from MGUS to myeloma. And that signature by NMF, by non-matrix factorization, was able to also detect, when we applied it to COMPASS data, which is the overt myeloma data, it showed us a progression-free survival and overall survival difference, and it could be predictive of prognostic risk in those patients. So if you put that in those patients, as well as looking at the proliferation index, you can actually stratify the patients as low risk, intermediate, and high risk, even in the COMPASS data in those patients. We then applied it to the gene expression data, the old gene expression data from MGUS to myeloma, and indeed show that this can be predictive. So again, not only genomics like DNA data that we have, like MAP kinase mutations and so on, can be predictive of who will progress. Now at the RNA level, we also have a gene expression profile that can be predictive of who will progress and who will not. So moving on to the immune system, here I'm showing you that the tumor system is an ecosystem. You cannot look only at the cancer cells. You need to look at the cancer and immune cells, and of course non-immune cells, to understand better what causes progression. So the first thing we did a few years ago is, again, we did single cell sequencing of the immune cells in the bone marrow from MGUS smoldering to myeloma. And indeed, what was surprising is we found that there were compositional changes that happened as early as MGUS. It looked almost like myeloma. And we were shocked because we usually think that MGUS is a benign disease. You're walking around, you have a very small chance of progression. Why would your immune system be so altered that it looks like myeloma? So we found Tregs are increased, CD16 monocytes are increased, NK cells are altered. And then later on, you have further functional changes. You have loss of the memory cytotoxic CD8 T cells, and then you start having less granzyme K, which are the earlier stem cells, and more granzyme B in those patients. And this is just showing you some of those changes. You can see here those memory cytotoxic T cells almost completely depleted in patients with smoldering myeloma, with overt myeloma. So we went on to ask a couple of other questions. One is, are those changes altered if I treat someone with smoldering myeloma? And can we expand that in also the peripheral blood of those patients? So this is work by Romanos Bistofidis, just got published a couple of weeks ago, again, also in Cancer Cell, where we took samples from patients on a clinical trial with ilutuzumab, lenalidomide, and dexamethasone, 51 patients who were treated on a high-risk smoldering trial. And we took samples baseline, cycle 9, and end of therapy. And what we found is, we found a couple of things. First is, of course, the compositional changes were very similar to what you expected in our other study, but now it's a much bigger number, 190 samples. So indeed, more Tregs, more CD4, TNs, and so on. But what we found that was interesting is a couple of things. One, because we had single cell TCR sequencing on all of those patients, we found that you actually have a significant change in the diversity of the T cells, even in early smoldering myeloma. So this is just showing you, when I resample the TCR in all of those patients, always we had a smaller diversity in the healthy compared to smoldering myeloma. So it shrinks significantly. And you would think that it shrinks because you have one clone that expands, so the diversity is smaller. And indeed, it is clonal expansion, but it's not just one clone, it's multiple clones, and some of them are very small clones that expand in those patients. Now, interestingly, that expansion was mainly in granzyme B CD8 T cells, as well as Tregs. And you can see it here nicely that those clonal T cell expansions were in the CD8 TEMs in those patients. So that tells you the immune system is trying to react to the cancer cells, but it's exhausted and it cannot do a very good job in responding to those cancer cells. And that could potentially be useful for therapeutic interventions in the future, especially with TCR therapeutics as we go on. Now, the other question we said is, can we use the immune system as a biomarker of disease progression? Can I use an immune signature that tells me this patient will respond to therapy or not? And after therapy, did they normalize their immune system? So indeed, we found a signature that is predictive of response, which is if you are reactive to the tumor cells, then you have a better chance of responding to therapy and a long-term progression, free survival. And post-therapy, if you normalize your immune system, indeed, you have a much better progression-free survival. And that tells us that indeed those patients can have that normalization of the immune system along with MRD. And we're hoping to apply that for all of the future studies so that you don't only look for MRD, you also look for PIN in those patients, post-therapy immune normalization. And this is just showing you some of those factors specifically for granzyme K as you go on to that normalization in those patients. Now we moved on into the blood and said, can we use the blood instead of the bone marrow again in those patients? So indeed, here's just showing you the volcano plot of those patients. And indeed, you have the same changes in the blood as you have in the bone marrow of those patients. And the same thing also happens for the T cell receptor. So this is just showing you the T cell diversity in the peripheral blood, and it mimicked exactly what happens in the bone marrow of those patients. Not only that, if I just do another confusion plot and say, give me randomly anyone who has a peripheral blood sample, and I will tell you if they have MGUS or not, it was very predictive in the blood by the immune cell signature that I can tell you this one is healthy, this one is MGUS. Now that opened the door for us to say, can we use it also for cancer screening in general? And this is something that we're trying to develop right now. So with that, we have big data, big questions, which means that we have 370 new samples that we sequenced, bone marrow and peripheral blood, to really ask those bigger questions of immune regulation in MGUS and smoldering myeloma. And now you can have more expression data that really defines the progression signatures, because you have more samples. You can differentiate what causes progression from MGUS to smoldering to myeloma, not causes, what is associated with it. Hopefully causative would be all of the functional studies that we can do in vivo and in vitro to say what is really causing progression in those patients. And then, of course, at the gene expression level, so at the compositional changes, most of the things happen at MGUS, and then they stay constant or increase slightly. But at the signatures of the genes, you have a huge difference in interference signaling. You see that sudden change of granzyme B increasing, and you have more of those granzyme B CD8 cells that are more senescent, as you can see here with their expression of KLRG1, and less cytolytic. So they're not capable of really responding to the cancer cells. And this is just showing you how altered the immune system goes on from progression from MGUS to myeloma. And then again, because we have so many samples, especially low risk smoldering, which we think is likely more like an MGUS, and some of those MGUS look more like smoldering myeloma. So the clinical factors of what we call MGUS and what we call smoldering myeloma may actually be biologically completely different, and they are intermixed, that MGUS and smoldering myeloma may have biological relevance from each other. So you can see here huge diversity changes that occur in some of the MGUS samples as well as the smoldering myeloma samples in those populations. And then finally, we're starting to look at the spatial transcriptomics, but until then, we started to look at the cells that basically are adherent to each other. What is close to a myeloma cell when we pull it in a CD138 selection? And indeed, we found many of the B cells, granzyme K positive cells, and megakaryocytes were highly attached to the tumor cells, indicating that there is a lot of interaction between those cells. So in the last few minutes, I'll talk about clinical interception. And we have done many clinical trials throughout the years, but now we're thinking of it more of that specific interception, being precise in our interception, what we call precision interception. So in the older days, we have shown there is a proof of concept that indeed observation versus treatment is better in progression-free survival, and in one case, overall survival with the lenalidomide and dex studies. But these were early events or early attempts. Let's do something better than that. So our efforts are divided into early prevention, metformin, intermittent fasting, things that really prevent progression. Then we have targeted approaches, MAP kinase mutations, 1114 with venetoclax. We're looking at synthetic lethality in 1q abnormalities and so on. Then we have immunotherapeutics, vaccines, T-cell therapy with CAR-T and bispecifics, and so on, and then novel combinations. And we're doing now 4-drug regimen, DARA-RVD, which is basically the standard of care of myeloma, bringing it on into an earlier setting, with the idea that can we cure the patients at the earlier precursor stages, and at least can we make sure that we do never develop end organ damage in those patients. So I'll just give you a couple of examples of those trials. This one is ongoing right now, ImmunoPrism, and this is the first time we treat patients with immunotherapy in smoldering myeloma. So we chose these inclusion criteria for high-risk smoldering myeloma, and we're randomizing patients 2-to-1 to teclistamab, a BCMA-CD3 antibody, bispecific antibody, or Lendex. Our first 6 patients were only teclistamab because the FDA mandated that we go very slowly and we do low dose reduction. And then now we're actually randomizing patients, and we're up to 18 patients currently either treated or going to treat soon with a primary endpoint of response rate. And I can tell you preliminary, we are not seeing the same rate of CRS. We are not seeing the same rate of infections you see in other patients, and we're seeing impressive responses in those patients. And then, of course, the other option is, can I use the one and done CAR-T therapy as early as possible when you have less tumor burden and when you have better T-cell response? And potentially, will this be a curative intent in our patients? So we're hoping to open soon the first CAR-T therapy in early precursor settings in high-risk smoldering myeloma. And I can tell you, when I submitted it to the FDA, the first thing I got back was absolutely not, you're not doing this. And we were able to convince the FDA to give us the IND, and we're hoping soon to open that trial. So with that, I hope I convinced you that early detection and early interception in one disease like myeloma matters, and hopefully this can be applied to many other diseases, and we can change the survival of our patients. And I want to thank, of course, amazing people, the lab, the clinical teams, and our collaborators from really all over the world, but of course our funders, Stand Up to Cancer, MMRF, LLS, NIH, our collaboration with Gary Getz, who just basically does everything with us at the Broad Institute, and above all, our patients. Thank you.
Irene, absolutely spectacular, incredibly, incredibly exciting. So we have Dr. Niparitzi here as our panelist too. And maybe I have a quick question. Do you see correlations between, the mutational spectrum and then the immune environment?
Yeah, great question.
And how do they?
Yeah. We haven't even started putting it together. I mean, so if any bioinformaticians you have, please come, because we have enough data for many, many years to analyze the data. But yes, now that we have that many samples, you can start asking the question in an 1114 or in a certain mutation, what are the immune dysregulations? The older samples were very small numbers. And of course, if you start subdividing it, P53, KRAS, 1114, you don't have enough data. But now as we're enlarging the cohorts, we will start to see that correlation.
Natalia, do you want to ask a question?
I think there is a question in the chat, but Irene, congratulations on your really tremendous success. And in terms of PROMISE study, I think that's really a successful enrollment and extensive data generated there. In terms of potential future clinical applications, I mean, terms like number needed to screen are used for breast cancer. 80 or 100 seems acceptable. What's your sense of number of needed to screen potentially for high-risk patients with myeloma, or perhaps those with family history?
Yeah, great question. And this is indeed exactly the question of how can we make it standard of care? What is needed for us to switch to an early detection? I think unlike breast cancer and other solid tumors, where you know that if you cut it and the patient survived, in MGUS, if you find it, what's the relevance, right? Because we know sensitivity and specificity is very good. So that's not the problem that we have. So I think what we have thought of is actually, let's show that indeed interception matters, because then early detection would matter. And 13% prevalence is a huge number. I mean, these are not numbers you see in any other cancer, right? Breast or lung and all of those. So a high risk population, being African-American or of African descent, or Black, or first degree family members, should be such a low hanging fruit. Like, you don't need to justify numbers needed to treat with a 13% prevalence. And that's just MGUS. If you add the MGIP, which could be detecting lymphomas, now we have a huge number of people walking around with early lymphomas and myelomas.
And if I may just ask one more, in terms of, I think you had some of this in the slides in terms of, fasting or metformin or other metabolic interventions. What's your potential vision on preventive intervention for those who you capture as MGUS or early stage? What's your current counseling that you provide?
Yeah, so the interceptions are easy because I can give something and I can see the response, but then so many patients have those earlier factors, and there's a lot of questions of obesity, microbiome, metabolic pathways. So we're starting to do now microbiome studies. We're starting to do metabolic changes and immune, and again, they come together, right? The microbiome, the metabolomics, and the immune dysregulation to lead to progression. So a lot of that effort we're starting to work on, because that can also be therapeutically intervened with, whether you have microbiome therapy or, of course, other mechanisms. And then Catherine Marinak and Betsy O'Donnell are amazing in trying to develop other studies like that, metformin, intermittent fasting, exercise, and fitness, things that can really help modulate the lifestyle of patients for, modifications, basically, that can help prevent progression.
Yeah. I think your former answer to Natalia may have answered the question in the chat by Manju Prasad, who's asking, is risk stratification for MGUS being offered to patients in the clinical setting?
Yeah, so actually our publication that just came out yesterday in Lancet Hematology was specifically to ask that question, because many of our patients don't have a bone marrow biopsy. So you think they have MGUS, they actually have smoldering myeloma, and then you don't even know. And as I said, the clinical annotation of what is MGUS and what's smoldering myeloma is so hard because the bone marrow is patchy. So I can have a 10% plasma cells, but I'm really MGUS or I'm not really small vein myeloma. So the Pangea model was actually 6,700 participants where we annotated all of their clinical data and we developed the clinical model of progression based on dynamic numbers. If their M spike is increasing, if their light chain is increasing, hemoglobin is decreasing, creatinine is increasing. Remember, all of those are blood things. And then we added bone marrow as well as age. And we did the model with or without bone marrow biopsy to help you really say, if I have a bone marrow biopsy, here's the risk. If I don't have the bone marrow biopsy, here's the risk. But it was a model for all MGUS and small vein myeloma. So I would use it. It's available online, the risk calculator. So look up Pangea and hopefully you'll be able to find it.
That's fantastic.
And considering the fact that so many of these younger patients who are diagnosed with full-blown myeloma in their 30s or 40s, you have to concede that they're likely have had MGUS from their teenage years. So I wonder if you have any germline genomic data within the PROMIS cohort or elsewhere.
Yeah, so we are trying to sequence right now all of the samples with whole genome sequencing. The MGB cohort already had either SNP arrays or now they're actually redoing whole genome sequencing in the same samples. And then, of course, many of those other cohorts had already sequencing. So you're right, we're trying to actually do that, all of the germline sequencing data.
Okay. I think we're having some static.
Yeah, I'm not sure if it's from me or from somewhere else.
It's okay. It may have been your computer, but let me. So Lourdes Mendez is asking a question in the question and answer. So how do you think of MGIP compared to lymphoid clonal hematopoiesis? And is MGIP in the absence of lymphoma CLL a manifestation of lymphoid clonal hematopoiesis? And then any information on overlapping somatic mutations?
Yeah, so great question. So we work very closely with Ben Ebert and Lachelle Weeks and others to understand really the interlink between CHIP and MGUS. And we are, as we speak, trying to sequence all our samples for that. It's hard to know whether there is an overlap of the mutations or not. I think we need to first see how many of them do have CHIP. And then we try to understand. We worked with Dan Lando, where we took some of our CHIP samples from myeloma and we did the single cell sequencing data, but most of the CHIP mutations were in the myeloid lineage and not in the lymphoid lineage. But that brings up the lymphoid CHIP question. And again, until we have more data, we don't know the answer, but it's a great question.
Awesome. We have another question from Amr Zaidan, and I think this highlights how important it is that we think mechanism and disease agnostic and across specialties. So Amr is, of course, loving your talk. And then, right, we have similar issues in CHIP, CCAS, low-risk MDS spectrum in terms of difficulties of response assessment. And so what do you think the primary endpoint of early phase trials for high-risk smoldering myeloma should be?
Yeah, it's a great question because if we wait for progression to myeloma, especially if you treat them in the observation arm with Rev-Dex, you'll wait for another 15, 20 years. So we do have a meeting with the FDA, which actually is in Madrid, to ask those questions. What are the endpoints? Can we get accelerated endpoints? Can we look at response? Can we look at MRD? Can we consider cure as a sustained MRD negative disease for 4 to 5 years? These are all great questions that we need answers to be able to design studies properly.
Yes, let me maybe go back then to the interplay between the immune system and your clone. So do you expect that if you get rid of the malignant clone, however small, that it would have an effect on the immune system?
Oh, I don't know. That's a great question. Will it normalize, right? I mean, if you look at the therapy we gave to those patients and when they were MRD negative, they normalized their immune system. But the other question is, which one started first? Is it the chicken and the egg? And was it already an immune dysregulation that led to those clones growing? And is that already there, even when you get rid of the of the clone, that years and years later, yet another mutation will occur because the soil is fertile, right? So I don't know. And I'd love to get samples, for example, from patients before they develop MGUS, so that we know which one happened first. But these are all great questions that we would love to collaborate with people and answer them together.
Awesome. We have a little more. Natalia, any questions from your team?
Yeah, I mean, I think perhaps to answer Amar's question, perhaps an immune endpoint should be a potential secondary endpoint, how to normalize that immunosuppressive environment. You know, what potential interventional strategies, like whether it's nutritional or microbiome or metabolomic strategies could be. I don't think we pay enough attention to weight loss interventions or exercise interventions in myeloma, and there's so much data. You made parallels, Irene, with breast cancer, and there's so much commonality between the diseases, the role of inflammation, the obesity, etc. So I don't think we pay enough attention to those kind of interventions in myeloma prevention and even relapse prevention once you have successfully treated them. Your thoughts on that?
No, absolutely. And I think you and Betsy O'Donnell would really, talk for hours, because we're even thinking, should we use some of those new obesity drugs, right? Like, there are so many things that we can do to prevent progression, and some of them may be, in our hands right now.
Yeah, excellent. So we're getting close to 1 o'clock, and I don't see additional questions. Irene, thank you so much for this really spectacular grand rounds, and congratulations on these amazing advances that are clearly, advancing prevention, which is so amazing for many patients, and then treatment. So thank you for sticking through, with the Zoom only option, and we really look forward to, getting together in person and collaborating for sure.
Absolutely. Thank you again, and definitely look forward to seeing you all in person, but this was a good alternative.
Fantastic talk, Irene. Thank you so much.
Thank you, everyone.